Helen, as I said, is one of our lived experience partners. She's our first speaker, and today she's here to share her lived experience of using health and care services. If you have any questions or reflections, please do share in the chat, as I've mentioned. But Helen Hassell is a parent carer, an active member of the My Life Choices co-production group with Nottingham and Nottinghamshire Integrated Care Board, and a member of the NHS Assembly since it was founded in 2019. So a wealth of experience there, and I will pass over to Helen now so that she can start to share her thoughts on the manifesto and moving things forward from those suggestions we've made.
Thanks so much, Sharon, and thank you for inviting me to be here this afternoon. Just to give a little bit of context as to my lived experience and why I'm talking today. So I'm an unpaid carer. I've got 2 grown-up children. I've got a 27-year-old, nearly 28, with complex medical needs, learning disabilities, physical disabilities, and autism. And I've got a 25-year-old with Asperger's. So it's been a busy lifetime. And I've certainly not been, I don't know, having lots and lots of spare time on my hands, I guess. And I think because of our recent experiences around accessing health and care for our 27-year-old in particular, I'm really mindful about how tricky the landscape is out there. We all know the reasons. We can all be super kind about it. And I think we should be super kind about it. But that doesn't take away the fact that it's a tricky landscape out there, isn't it? And I think for me, one of the key things that people like me want to see is moving into this election period is a real commitment to true, meaningful patient partnership. And there's lots of different ways to work with people and communities. It's, you know, the gold star is maybe strategic co-production, where we work at, you know, with senior system leads. And, you know, for me, I get to work with some of the NHS England board in the Assembly. But equally, co-production and patient partnership can be done on a one-to-one. How do we have those conversations when we do get to act with clinicians? And although the landscape is changing and the cultures are shifting, I think when I speak to people like myself who need to access health and care system a great deal, there's still very much a suggestion that actually let's do this to, not do with. And I think there's a real shift about needing to look at personalising care and looking at real person-centred practice, excuse me. And that really came out the NHS at 75 report that was published last year. And as an Assembly, we put out lots of consultation work, pulled together a document. And I think I was quite surprised to see that the depth of feeling around true personalised care approaches. It feels to me that was all part of the long-term plan. We're well into that long-term plan, which has obviously had to shift to some extent through the pandemic. But it seems to be that the messaging is getting across to the public. People want to share what matters to them. You know, gone are those days where it's very definitely a done to when you go to see a clinician. We want to do with, we want to bring in that shared decision making. We are more than what is just wrong with us. And that's certainly something, Sharon, that I have felt with my young person as I've taught him to take more and more control and to have more and more choice into how he wants to access health in particular. I think the other concern I have is not going to surprise anybody. The NHS is a political football, and we're living in a period where there seems to already be things that are just thrown out into the media to see what. There's this, you know, very definitely a reactionary type mentality. What's going to get the biggest bucks? What's going to get the most votes? And this is all, for me, short-term thinking, and there's not a long-term agenda here, which is why I think the manifestos are so important, because it really focuses people on to really what matters to organisations like the ones that are represented. And there are others that have done, you know, quite a lot of work around what matters to patients. I'm thinking, you know, the Patient Association have got their 6 key principles that really work, and I think the 2 work together really well. You know, in a blue sky thinking, I'd love the NHS to not be political. I'd love it to run as a big business, but I appreciate that's naive at best and probably not happening in my lifetime. And I think that's interesting, isn't it? Access is tricky, as I said, and it's not just the big hitters, you know, dentistry, GPs. For us, it's also about accessing support for somebody with a learning disability, for autism. There's a lot of issues around waiting lists if you need to get an assessment done for a child who may be neurodivergent. We've got families that I support in my spare time that are waiting above 2 years for an assessment. Now, a child changes hugely within that period of time, and their needs at the point of assessment are very different to the needs that they might present with to begin with. And in amongst all of this, they're just left in a holding pattern with no support and no communication. And communication is key for me. I think if we're going to have to wait, we need to be able to wait well, and we need to be able to wait with communication. Don't leave us as islands on our own. Don't leave these families who are struggling completely isolated and not knowing how to manage things. Let's communicate, let's work better. Let's stop sitting in our silos and saying that's a health problem, that's a care problem. People like me don't sit in one system or the other. I sit and straddle all of them. And I don't manage to pigeonhole my needs into one area. I think for me, we've had a really tricky year accessing services. My young man's been quite poorly. And we've had a year where he's been quite unwell. He has a lot of neurosurgical interventions. And one of the issues that has really surprised me is around innovation and technologies, and the fact that in my local system, we can access a piece of medical kit that has or could be life-changing for him. So every time we need to check his brain pressures, somebody has to drill a hole through his head, attach monitors, and we then need to watch him. Now that brings a vast array of issues, least of all trauma for him, before we then start looking at expenditure and what matters to him. Fast forward a year of really tricky stuff going on for us as a family. He's accessed a different NHS trust, has an implantable device in his head that we can now wirelessly monitor the brain pressures. It all sounds a little bit sci-fi, doesn't it? But actually, how do we look at innovation around our health and care system? And that's got to be a long-term plan, not a short-term quick fix it in this election year. And I think certainly when I speak to parents and I speak to people like myself that are accessing the system, we want to be able to grab these innovative approaches and innovations and technologies wherever we live, not just as a bit of a postcode lottery, which I know we see in other things as well. The NHS 75 report from the NHS Assembly really reflected on the strengths of our system. We're free at the point of access. We don't want to lose that. I'm aware that it's probably the only one in the world that works quite like it does, and we should be celebrating it. Which means for me even more so, let's not use it as that political weapon. Let's not use that to try and score points off one of another. Let's look at what matters to people, and let's really celebrate that we've got this amazing system with an amazing workforce who all want to work together collaboratively where possible. Care closer to home. How many of us have to rock up to hospital appointments just to be there for 5 minutes to tell us that we can go home again? Outpatient appointments for you as a clinician might be 10 minutes of your life per patient. For me, it takes out half a day. By the time I've travelled, I've gone through the stress of parking. I've maybe calmed a meltdown or two because we don't want to be going. To then actually go in, have less than 5 minutes in there going, actually, I've got nothing to tell you, seems to be an inaugural waste of my time when there are other methodologies that we can use to speak to families. Co-production. My life choices in Nottinghamshire really demonstrate that if you work with the system, in an equal partnership, and you cede that power as a major system lead, and you really work on balancing those powers, you can achieve great things. And in Nottingham and Nottinghamshire, we have done around the personalised care agenda. We're training people, we're helping to run events, and we're really getting the voices of people out there to really shift that culture of understanding what matters to you. And I think for me, that's the big shift, isn't it? It's the cultural change that takes time, but we're seeing it growing, we're seeing it gather momentum. And I think for me and others with lived experience, let's just see this carry on snowballing until the whole system works in the way that we would like to, and not in isolated, little parts of it. So hopefully that's whet your appetite for Anna and for Jacob later on. Any questions, put them in the chat, or we'll come to them in the Q&A at the end. Thank you for listening.
Thank you, Helen. That was such a fantastic talk to open to, and so nice to hear you talking so openly about some of the trials and tribulations you're facing as a family. Some of the things that really stuck out with me was when you said we're more than just something that is wrong with us. I think that's such an important thing to get out there. And going down to some of the basic issues, I myself have long-term health conditions. I remember driving around looking for parking all the time when I was little, and it just drove my mum mad. But those kind of things, that's kind of the reality of what we're talking about when we talk about patients engaging. I really liked you called it out, saying, there is trauma involved in a lot of the things that happen to people. I don't think we think about that quite often enough as a system. And I loved your final point about your ICB having to cede power, because quite a lot of patient-centered, person-centered care is about finding the courage from clinicians to cede that power. So I want to say thank you once again. I will now introduce Anna to switch between screens. Anna Quigley, thank you so much for joining us. She will be our next speaker. She's going to be looking at how the political landscape looks right now and health and care issues for both voters and politicians. So Anna, a research director at IPSOS UK, please do start your speech. I'll hand over to you.
Thanks, Sharon. Hi, everybody. Lovely to be here today. I'm Anna Quigley. As you've heard, I lead the health and social care team at IPSOS. And today I'm going to just share some of our latest polling with you in this sort of pre-election period, however long that period might be, just to sort of see what will health be in this election, how important will it be, what are we likely to be hearing about. But first of all, before we sort of move on to that, I really want to take a step back and think about the wider context at the moment and where we are as a country. What's the mood in the country? And of course, I think it's pretty low. I think people have a lot to deal with at the moment. We're hearing people talk about so many things that are worrying them. And our polling has really picked up this trend. So back in 1998, we had 4 in 10 people saying that Britain was getting worse as a place to live. Fast forward to 2023, that figure has increased to 76%. 3/4 of people say that the country is getting worse as a place to live. And there's lots of reasons for that. There are multiple crises that people are dealing with. They are seeing the effects of climate change here, abroad. They are seeing conflicts around the world. They are seeing conflicts between different groups at home. But one of the main things we hear people talk about time and time again, of course, is the cost of living crisis. And that's really what's worrying people at the moment. And what's really worrying about that is that 6 in 10 people think that the worst is still to come when it comes to a cost of living crisis. So something really concerning. And those economic concerns are matched by real worries about the state of public services at the moment. So again, at the end of last year, we had 8 in 10 people saying that the quality of public services had got worse over the last 5 years. And again, that's a trend that's really rapidly increased over time. So back in 2012, so just over 10 years ago, that was 4 in 10. That's now doubled to nearly 8 in 10 people saying the quality of public services has got worse. Now, of course, one of the public services that we know people care about is the NHS. And we ask people every single month, what's the most important issue facing the country today? And last month, we saw the NHS rise to the top of that. So more people said the NHS was the most important issue than other things like inflation and the economy, which had been dominating things. And as I said, we've been tracking this every month for well over 20 years. And what you can see on the chart here is the proportion of people who say the NHS is the most important issue facing the country. And what you can see is there are peaks, usually around election time. And we just heard Helen talking about it being a political football, because it is. Politicians talk about it because they know that people care about it. And we always see these peaks in run-ups to the election. And we also know that health is a really important issue for voters. So we ask people, what are the issues that are going to help you decide who to vote for in the election? And last month, again in February, we saw health at the top of that. So 3 in 10 people said health is the thing that's going to help them decide who to vote for. And again, that's followed by inflation and the economy. So it is something that we know is important to voters, and it it's really important. We know that Labour have got a really big lead in the polls at the moment, but there are still a lot of people out there who haven't decided who they're going to vote for or may still switch. And I think in any of your campaigning work, you should be pushing at an open door. Politicians should want to talk about these issues, should really want to know what it's like for patients, for service users, for the families, because they know how important it is to winning them votes. What's different this time? I said that we always talk about the NHS. We always see that peak around election time. But what's different this year, of course, is that we've got satisfaction at an all-time low. So 2/3 of people, when we asked them last year, said that the general standard of care provided by the NHS had got worse over the last year. And you can see that figure has increased steadily over the last few years. And you've probably heard that in other surveys as well. And we're certainly seeing it in our patient experience work. So things like the GP patient survey, a really large survey that goes to people registered with GP practices. We've seen historical lows in terms of the ratings of patient experience, largely around access, not so much about the quality of the interaction once they get in the door, still quite as positive, well, still very, very positive about that, but really massive concerns about access. And they're also worried about its future. So think it's got worse, and they also think it's going to continue to get worse. So we've got 2/3 of people saying that they expect the NHS to get worse over the next few years. It's the highest proportion saying this in 20 years in our tracking. And you can see just how that proportion saying it's going to get worse has increased over the last decade or so. But despite all of that, despite these low levels of satisfaction, we know that the NHS is dear to people's hearts and people really, really care about it. So much so that we've got 7 in 10 people saying that the NHS is crucial to British society and we must do everything we can to maintain it. So how do you do that? More money, of course, is one of the answers. And 8 in 10 people think that the NHS needs an increase in funds. What are their priorities within the NHS? Where do they want any money to be spent? Mainly around staff. So we've asked people, when it comes to the NHS, what do you think should be prioritised? Addressing the pressure on or workload on NHS staff and increasing the numbers of staff are the top 2 answers. And that's partly because they think that it will affect the other thing they really care about, which is access, which we've already been hearing about. More staff, we will improve those waiting times. And that's what's really critical to people, as we've been hearing already. And I think this echoes our wider work. So we also do lots of work on public services as a whole, and again, ask about priorities for improvement. And what we hear from people about that is just availability. Again, it's ease, speed of access. It's all of the things that I think will resonate with people here who are well aware of the issues within the health and care sector. And when we ask about contact, so what do you want to improve when it comes to contacting services? The things we're hearing at the top are not having to repeat details every time you use a service. And I know that will resonate. And then being able to contact them at different times of day, at the weekends, and being able to use different methods, offline and online, but different methods of offline contact as well. So again, this is what we're hearing consistently when we talk to people about public services as a whole. And I think these are very much true within the health and care sector. And I know Jacob's probably going to talk about sort of getting those basics right. And that's definitely what we're hearing as well. But as I said, people do want to put more money into the NHS. But it's not just that. I think this is a change that I've noticed over the last few years, talking to people. We're really hearing a sentiment about you can't just keep pumping money into the service. And you can see on the chart here, so 6 in 10 people say the NHS needs to make big changes to the way it runs and provide services in order to improve, as well as getting more money. So it's not just about money, it's about doing things differently. And I think this is something, again, that I've just not heard in previous years, a sort of recognition that the NHS that was conceived of 75 years ago probably isn't the service you would design if you were going to do that today for the population that we have today and the needs of today. And so there's an understanding that there's lots that we value about the NHS, particularly its founding principles, that thing about it being free at the point of use. But there's lots that people think, well, maybe we should be doing things differently if we want it to continue for us and be there in the future. And we're also hearing that people recognise that the NHS can't fix its own problems. There's this dependency on social care. Now, you'll have noticed I've talked a lot about the NHS during this presentation and not much about social care. And that's because I don't think social care will play a massive role for politicians in the run-up to the election. It's very difficult for them to talk about for lots of different reasons. But perhaps that's a mistake, because the public gets that the NHS doesn't exist in a vacuum. Yes, they want to improve the NHS, but actually when we put a list of options to them and said, what's the thing that's going to make the biggest difference to the NHS? The one that came out top was increasing capacity in social care. So they really get that link between them. Yes, they want waiting times to go down, but actually they understand how important social care is just to achieve that in itself, apart from all the other things that social care does. They also, and this echoes very much what you've just been hearing from Helen as well, this willingness to think long term. So what we hear from people is, please don't make radical changes. We know that the NHS is going to be important and health is going to be important in the run up to the election, but don't make it a political football. Don't just announce radical changes that are short-term vote winners. Think about the long term. Think about actually what changes do we need to make now that are going to mean that this NHS that we have grown up with is there for us in the future, is there for our children, is there for our grandchildren. And they are willing to embrace change and use services. We were hearing about innovation, and that's something we hear a lot about from patients and the public. There are concerns about maybe leaving some people behind when you're doing things differently, particularly around tech and digital methods. However, there's a recognition that, you know, this is something that could change and could safeguard the NHS future. So a willingness to get on board with that. So just some final thoughts from me. I do think the context is really important. The mood of the nation is low for many reasons, but particularly people are worried about the cost of living crisis and how it's hitting them in their pockets, but also the state of public services. The NHS is chief among their concerns when it comes to public services. There is low satisfaction and there's real worry about its future. And we are going to hear about it a lot in the run up to the election. I think politicians will be talking about it a lot. Probably not going to talk about social care as much, but we saw that the public do get the link between them. And the final thing is just that willingness to think about long term, to think about prevention. These are things that the public are willing to embrace and want to hear more about. So that's it from me. I hope that was useful and looking forward to the rest of the session. Thank you.
Hi, Anna, that was totally fascinating. I could drill down into all bits, loads of bits that I liked about that. I mean, it's a bit of a shame, really, that the public aren't running the priorities of the government when it comes to the NHS, because obviously to hear social care at such a priority when we know that that most parties aren't focusing on that because it's so difficult to resolve. And as much as there was lots of kind of bad news in that, I was actually really heartened to see that the public felt that focusing on reducing staff pressure and increasing the number of staff was also a huge priority for them, because it must be very frustrating. And we do know from lots of media reports that the NHS staff themselves can feel quite demoralised, that they know they're working in a system where pressure is much too tight and they're not delivering the care that they would ideally like to. So it was actually really nice to see a public that recognises the pressures on staff and also the need for social care. And I think a lot of this will come out and speak to some of the issues that we pulled out in our manifesto asks, especially around this idea of a willingness to get on board with tech, but not to leave everyone behind, which is great. And also the desire that there needs to be a change in services. So that's 6% of people who felt that there needs to be more money, but also a change in services. So I felt that was fascinating. So much information in that, but I will pass it on to our CEO, Jacob, now, who will outline our manifesto asks and no doubt link into some of that fantastic information that you presented, Anna. So thank you.
Thank you, Sharon, and thank you, Helen and Anna. I just kind of want to get sidetracked from my presentation now and just talk about what you two just presented, because as Sharon said, I'm never surprised that when you engage the public, whether it be on a one-to-one level as a person with lived experience, or it might be a mass quant survey, that actually people are pretty reasonable and they've got very clear ideas about how we could fix the NHS and the social care system. And it's just a shame that some of that gets lost in the politicians thinking they know what people want. And so, yeah, but I won't get sidetracked on that. We'll leave that for the Q&A. As Sharon said, I'm just going to talk a little bit about the manifesto asks that National Voices is putting forward. And firstly, I just want to say a big thank you to all the people who've contributed to helping us produce this manifesto, because we haven't just locked ourselves in a broom cupboard somewhere and just come up with a bunch of ideas. It's very much been pieced together over a number of months, firstly with the staff team, bringing together and synthesizing what all of our members have been up to over the last couple of years, looking at your work, analysing the issues that are concerning to you and to the beneficiaries and the people you represent, and really kind of going through that and looking for the cross-cutting areas where National Voices can make a difference, where we'll add some value to the sort of campaigning and influencing work that you are doing individually. I think also want to say thank you to all of the members who then took part in our heads of policy discussions over the autumn. Those are really important for helping us crunch down the long list of ideas into really the 3 crunchy topics I'm going to talk to you about today. And last, but by no means least, I want to thank also the partners, so the think tanks, people like NHS providers, ComFed, other patient groups, all the sorts of people who've helped us further test out our thinking on the manifesto asks. So that was the sort of the thank yous. I just want to kind of useful to explain where these have come from as well, these ideas. The second thing I want to say is that underneath all of all 3 of these areas I'm going to touch on is the underpinning principle of health inequalities. So that's something that's really important to National Voices, and we know it's important to our members, and not least the people who are affected by health inequalities, that we actively try and address the many problems that are out there. And so that runs through as a theme throughout the manifesto. It's a manifesto for equitable care, and I think that's something that I also wanted to get across, because sometimes when you produce manifestos, we're trying to land stuff here with some of our political audiences, and politicians often want policies that they can sell on the doorstep. And that often then means that they don't really pick up on the sort of the nuance or the kind of the detail that would really matter when addressing health inequalities. So I think it's bear that in mind. We've drafted it for a political audience, but it's really to try and land that principle of addressing inequalities. And I think the 3 areas that we've covered really give us the hooks that we need to build more detailed ideas with political parties, whichever one of them wins the next general election. So the 3 areas then that we're touching on. So the first one is about pioneering a cross-government approach or strategy to reducing the gap in healthy life expectancy. The second one is all about introducing an immediate package of measures to address the impact of the cost of living crisis. And the third one is all about getting the basics right, which I'll touch on what each of those mean in turn, and then we can open up to the Q&A. So the first one on healthy life expectancy. So we basically, this is one of the, as I mentioned about health inequalities being a real cross-cutting theme for us in our manifesto asks. And we wanted to make sure that in that first ask that we really produced got the concept that as many politicians could buy into as possible. They really understood a number, a target, the sort of thing that they really like to work towards, that we identified something that was going to put health inequalities into the language that politicians understood. And so we could have settled on this idea of looking at healthy life expectancy as a measure that not just the health sector, but also other government departments could all be contributing to how we reduce the gap in healthy life expectancy. And we know that gap, there are huge variations out there, huge inequalities that see some communities and some individuals and groups. Their healthy life expectancy can vary up to 20 or 30 years, depending on whichever report you're reading. And you know, from the NHS's point of view, that is additional years and years of additional appointments, medications, interventions. From the government's point of view, that's years of lost productivity for those people. But for us and everyone that we represent, we know that that's actually years of people living in pain that could have been avoided, living with uncertainty about what's happening to their condition, and what it means to their long-term health. It's years of people not being able to achieve what they want to with their lives. So it feels like this is a really important thing to address healthy life expectancy. Now, we're not the first organisation to talk about healthy life expectancy, and indeed, we're not the political parties are already talking about this themselves. But I think it's really important to understand the kind of the angle that we're trying to push with them. So in 2019, the Conservative Manifesto that actually pledged to improve healthy life expectancy by 5 years by 2035. At the moment, it doesn't look like that target's going to be met, because actually all the stats suggest we're going in the wrong direction on life expectancy and healthy life expectancy generally. But it's important to note the Conservatives have bought into this idea. They understand that healthy life expectancy as a measure, as a credible measure of how the country's doing on its health. Labour, likewise, have also talked about healthy life expectancy in their sort of health mission and for the future of the NHS. But from their point of view, they've talked about a desire to improve healthy life expectancy. So they haven't added a number to it like the Conservatives have. But they also have suggested that they want to cut the gap in healthy life expectancy between regions in half. So they want to reduce the discrepancies and sort of variation between regions. So it's important to understand that both political parties have bought into the idea of healthy life expectancy, but what both of them have missed thus far is actually the causes of that, and what's driving that is it's not just a variation between regions, and it's not just about extending healthy life expectancy overall. It's about understanding that there is variation between different ethnic minority groups. There's poorer outcomes and poorer healthy life expectancy for people from the LGBTQ+ community, people with learning disabilities. Actually, it's far more than just a regional disparity. We even have significant disparity in healthy life expectancy between postcodes and between roads. So we really need to have a very granular understanding. And that's what we're trying to do with the political parties and say, look, your mission and focus on healthy life expectancy is welcome, but you're not really understanding the gap sufficiently and how that needs to be closed. So that's where our ask comes in, really. Is all about trying to use a headline number, a headline target that the political parties are comfortable with, but get them to understand actually it's much more complicated than that. It's much more nuanced, and really galvanise the next government to have a cross-departmental approach to addressing healthy life expectancy. So we would see every government department contributing to a target. How are they going? How's DWP, for example, Department of Work and Pensions, going to address healthy life expectancy? How's the Department for Communities and Local Government going to do their bit? So it's something that all of the government departments can feed into to really address that underlying driver of health inequality. So that's the first one. That's that sort of the second ask. If we can move on to the next slide, please, is around the cost of living crisis. So I mentioned earlier that political parties like to have policies that they can sell on the doorstep to show how they're going to improve things, and actually a lot of these asks fall into that category of easily sort of packageable and saleable policy ideas. And it very much comes from this, what Anna was saying, actually, that the cost of living crisis isn't over. We know a lot that the public think that the worst is still to come in the effects of it on us, and that's very troubling. We also know that government programmes to address some of the wider issues around cost of living crisis, so the support with heating, for example, have come to an end. So actually it feels like the establishment's decided cost of living crisis is now over, yet the public's really worried about it. So we've called for here a range of package of measures that the next government could introduce specifically to reduce the cost of living crisis and its impact on health. So that would include a whole variety of different things, from support with hospital car parking charges, transport to help people get to appointments, all those sorts of additional costs that we know are actually a barrier to people accessing care at the moment. Likewise, it would be other policies like, as Helen was saying, you can't just take, lots of people can't just take time off work. That will be detriment to people's financial stability if we're asking them to take lots of time off work to attend appointments. We need the NHS to be much more respectful of people's time, of patients' time. So there's a whole range of different things in here about like measures that the government could introduce, from free prescriptions, for example, or free NHS dentistry, that would have an active role in reducing the impact of cost of living crisis on people's health, through to cultural signals that can send to the NHS about actually how do we work with patients to help them manage their conditions in more sustainable ways for themselves. Under this one, we have also included an ask, which I think is a really important one, because it's slightly beyond our traditional territory, but is about extending statutory sick pay. And the reason that we've included this one is that very much the NHS, obviously we know the size of the waiting list. It's over 7 million people waiting for elective care, waiting significantly longer than they had to previously, having to be off work longer as a result of that. And yet there have been no changes made to statutory sick pay to be reflective of those longer waits that people are experiencing. And so we've included that in there as an urgent call for government to address that, because these individuals are off work, sick, they are feeling the financial pain as a result of that, as well as the physical pain of waiting longer, all through no fault of their own. And actually it doesn't make sense in the current environment to not address the statutory sick pay situation. So that leads me into the third and final one, which I'll talk about briefly before we go to questions. And this is all about getting the basics right. So when elections come around, politicians are really keen to make big promises about the future. In particular, when it comes to the NHS, that often manifests itself as politicians promising X number of new hospitals will be built, or that they're going to invest X billion in artificial intelligence, which will transform care and make it more sustainable. But as we heard from what Anna was saying, actually public trust in government and public confidence in public services is pretty low at the moment. That's particularly true in the NHS, and I actually think that politicians making those bold promises aren't cutting through because people simply believe they won't be delivered on. And actually, we know there are a lot of real life, very simple things that the NHS is getting wrong at the moment, that if fixed, they would make a fundamental difference to people's experiences of accessing the service. So this ask is very much about how do we move politicians away from promising the shiny future of the NHS, what it will look like in 10 years, and actually get them to focus on some really important practical things of how they're going to improve care in the immediate time frame, how in the next few weeks, months, years, how is it going to get better? And that needs them to focus on a range of different things that they don't like talking about. So things like improving the admin processes in the NHS, and the need for a plan around how we're going to get the right admin support in place to help patients navigate the system, help sort of consolidate waiting lists, manage waiting lists better. How can we make sure that we've got the right support staff in place, so clinicians who we've got can concentrate on medical care. We also need, we need to think about how we help people wait well, because we've got these longer than usual waits for elective treatment, and that's going to require, again, some really basic things, but about regular communication with people on elective care, where they sit on the waiting list, when is their appointment likely to happen, and keeping them updated, making sure that appointment happens at a time that works for them, making sure that we provide adequate interim support to people whilst they're waiting with their mental health or with pain relief. And that could include signposting to, in particular, VCSE organisations who provide an awful lot of this support for people whilst they're waiting. What's the next government's relationship with the VCSE going to be, and supporting that infrastructure that's so vital for helping people have a good experience whilst they're waiting? It sounds like a basic thing to focus on, but it's the sort of thing that would make a real difference to people who are currently awaiting NHS treatment. Just quickly to wrap up this one, we've also included under here things like enforcing the accessible information standard. So we know, again, this is a very basic need for people who've got visual or hearing impairments. It might be a learning disability, mental health needs, might not be someone who speaks English particularly well, low literacy levels. There's all sorts of issues that are affected by the fact that we don't provide accessible communications at the moment. And so that's a real barrier. It's a real simple fix, but it's things like that where we think the next government needs to concentrate on. And I will pause there because I've given a lot of information on the what's in our manifesto asks. But I think that those three areas that we've got have given us a lot of opportunity to push our overarching messages with political parties ahead of the next general election.
Thank you so much, Jacob. It's really good to hear you talk through our manifesto asks. I think people will agree that there's quite a breadth there. We've got more of the longer term aim around reducing the gap in healthy life expectancy, the shorter term roundabout cost of living crisis, which we really know is causing people significant harm, and the kind of should be short term, but probably more medium term one around getting the basics right. Because I think, as Jacob pointed out, trust has really dropped amongst people, and that will take a while to regain, and it would be a matter of kind of proving that the basics are working. So for example, the inaccessible information standard, we've been waiting on a review and a refresh of that for almost a year. So it kind of shows you that it's such a basic ask, but admittedly it's something that isn't as straightforward as you would hope. We are now able to ask questions. So if anyone's got any questions for any of our panelists, that's Anna Quigley from IPSOS, or Helen Hassell, our lived experience partner, or Jacob. We've already had one come in advance, so I will ask that along with one of my own, because as chair prerogative, I get to do that. So the first one we've had in is how do we expect to use our manifesto work to engage with the public and bring the public into this kind of work that we're doing? And I know, Jacob, that will be quite firmly aimed at you, and maybe Helen, you'd like to come in on that as well. But one of my questions is, an ex-journalist, it's always quite thorny. We've seen that the public really want to focus on the longer term of health. And we know, for example, that Labour has said that it will take 10 years to clear the waiting list backlog, but equally Rishi Sunak has, as one of his promises in 2023, in January 2023, was cutting the NHS waiting list, which we know has risen in part because of the strikes that are ongoing. So how can we kind of get politicians to focus more on the long term, or is that not possible? So Jacob, over to you on the first, which is how to involve the public in our manifesto, and then I'll maybe go to Anna for the second one on long term.
Thank you, Sharon. So just quickly, I mean, I think the best thing to think about the manifesto work is squarely aimed at political parties and the teams that will be producing the manifestos to the political parties. I think it's unlikely that National Voice is going to mount a campaign that gets the public riled up and sort of writing loads of letters into their MPs about these particular issues. But I think it is trying to build on a sort of a groundswell of people and organisations putting these thoughts into politicians, that actually that it's worth listening to the public on what they want. It's about the health service, worth listening to the detail of what they're saying. It's worth working with them, because that's the principle we're trying to land with the next government, whoever it may be. And Anna's presentation talked to that. Helen's a shining example of how when you work with people with lived experience, you can really make a difference to things. So I think if we can land that sort of concept with political parties is probably sufficient. But I mean, there's also the kind of all of our work with our members. So where we can mutually reinforce each other's manifesto. So that's helpful for us repeating that message back, that actually when you listen to people and you talk to them, they're very sensible, they've got a very clear idea of what needs to be done, and you can work with them. So I think that's the kind of thing that we'll try and do in terms of our public communications around this. If I had an answer to the second question about how you get politicians to focus on the long term, I'd be a very wealthy individual. living in a much more sort of hopeful country, I imagine. So I don't know if Helen or Anna, if you want to pick up either of those questions.
Hi, Jacob. I mean, with the first one, I have to say, and I think that reflects in Anna's presentation, the public are weary. We're fed up, we're demotivated, and people like me that use both health and care systems a lot just see this election as another excuse for politicians to do not a lot. And you know, that might sound really contentious, but that's the reality. As an unpaid carer, nobody's going to be running to give me any help for the next 6 months while they're running around getting votes, are they? Nobody's going to knock on my door saying, how can we get paid carers in so that you can take a break? You know, it's not headline grabbing, is it? You know, the media might run a couple of nice stories about, you know, the percentage of people that are unpaid carers in the country, but realistically, the public aren't going to jump, as Jacob said, onto this manifesto. That said, I see a real opportunity for the member organisations within National Voices to pick up with the work that you're doing around the Voices for Improvement programme. We're seeing the biggest impact for change when we grow it from the inside. So I know Ken Worthing's somewhere on the call, and she heads up the Voices for Improvement work. So what can you do differently? How can you work with people with lived experience? How do we ensure that we're listening to voices that we don't hear from? You know, I accept I have privilege. I come as a white middle-class woman. I'm fairly comfortable. Who are we not hearing from? Not because they'd like to be labelled hard to reach, but because we don't go and find them, because we don't give them a voice. And I see a real opportunity to further embed the work that Kem and the team have been doing. Certainly multiply through all your different organisations to make a real difference at place, but also at system level. And I think a lot of the work moving forward, I think we will prove to politicians just in the doing that actually the short-term fixes don't work. And when we embed these different culture changes, that we will change for the long term. And I see that shifting in that direction, if I'm honest, Sharon.
Thank you, Helen. I don't know, Anna, if that last point gives you any thoughts about the longer term, or even if it is possible.
Yeah, I mean, I agree with Jacob. It's really difficult, isn't it, to try and get politicians to think about the long term. I would say that what I've noticed over the last year is, you know, they're savvy, aren't they? They know they're trying to win votes, and there will be two things going on in their heads. So there's the, what do I need to say to win votes, but what do I need to do long term to actually make a change? And let's hope that there are some politicians, I think there are some politicians who actually go into politics because they want to make things better. Not all of them, but you know, some. And what I've noticed is, we did some qualitative, some deliberative work with the Health Foundation, and they invited some manifesto writers along to actually hear it. So not just see a report at the end of it with some words on a page or a presentation, but actually come into the room and hear people, real people, talking about the issues. And I've always noticed this whenever we do work like that, whether it's politicians or whoever, you know, whatever the decision makers are, here being in the room and hearing real people say things is so much more powerful than seeing me present on it afterwards or seeing a report of it. So any opportunity that you get to engage and bring the public together with key decision makers, I think is the way forward. But I don't have a magic wand, I'm afraid, but that's my tiny little nugget, I would say.
Thank you so much, Anna. My thinking maybe is that there's more of an opportunity within the integrated care boards, which is kind of less political and more focused on change, that in terms of trying to get the longer term strategy that sits kind of beneath all the political football stuff. Jacob, I don't know if you were going to come in because I cut you off.
It was just a thought on getting politicians in front of people and actually getting them to see what we're doing. I mean, we are doing a bit of that where we've held a number of roundtables with Labour in particular. I attended a few Lib Dem ones and things, and actually just trying to get them, because I think sometimes what happens is the polling work is great, and that's what a lot of politicians often rely on. But your poll, for example, the stats you shared showed that 13% of people think that tackling health inequalities is a priority. And if I was a politician, I'd be looking at that going, well, 13%, that's, you know, whereas improving A&E performance is much, much higher than that. So I'm going to focus on the 4-hour A&E target. Whereas actually, when you get into the detail of it, we know that tackling health inequalities is going to be much more important to improving the sustainability of the health service, and that's also its experience for lots of people who are having the worst outcomes. So actually, that getting the real life stories, the real life experiences, and hearing it from people directly can say, well, the number might look low, but actually it's much more significant than that. So there's a bit of like trying to land the two things together for politicians, I think.
We've got three more questions in the chat, but do keep coming because we've got more time. I'm going to group two of them together and then come back to yours, Joseph. So the first one is a question from Caroline Davis at the Neurological Alliance. It's a question for Jacob. How much buy-in have you had from the Labour Party in West Streeton, and have you had any from the current administration? And then to follow on from that, I'm going to go on to Jessica Jones' question from MND Association, which says, do you think political parties view co-production and patient engagement as a hassle, which reduces expediency and chances of reaching their targets? How can we show them the benefit of supporting patients with long-term conditions to be empowered? So Jacob, I'll go to you if you want to kind of attempt to answer both those questions, and then we'll open up to Helen and Anna.
Yeah, I'll start. So just in terms of engagement with Labour, I think it's been incredibly positive to date. So last year there were a couple of roundtables with Wes and his team. We've had a number of meetings since, and you know, when we published this the manifesto asks, was it back in end of January? I was speaking to some of Sir Keir Starmer's team as well about the manifesto ask, and there's an awful lot of what we're producing, what we've included here, that resonates with their thinking. How much of it makes it into the eventual manifesto is another matter, but the point is that, you know, the manifestos are the sales pitch, but actually there's also the thinking that goes on about how you're going to deliver that when you get the keys to number 10. And so actually, I think it's sometimes that's as important. So there's a fair bit of traction, but it's not just to say the Labour either. So with the current administration, Sharon and I met with the number 10 health advisor, talked through the manifesto ask, and again, I think it was, you know, they can see what we're trying to get at. They can see the kind of why the sort of intelligent debate we're trying to insert into it. It's just how much you can cut through the size of the waiting list and the, you know, the A&E performance. That they're still struggling to get their heads around, like, that's the election battleground for them, not fixing the basics. So yeah, but it will be a continuing conversation with them over the coming months as we move towards an election, whenever it may be.
Also, just to add, Jacob, we didn't sit down and have a meeting with Daisy Cooper as well, Lib Dems.
Oh, yeah.
So it was a sit-down roundtable, and that went well. And obviously, you know, the polling says what the polling says, but we know that Lib Dem has before been the kingmakers, so it's important as well that we continue to influence as many people as we can. On the view of political parties viewing co-production and patient engagement, maybe actually I'll go to Anna on this one and then go to Jacob and Helen.
So I was thinking about this question because possibly yes is the answer to it, but I don't know, my view from listening to patients and the public is that the problem is actually the targets themselves. They're probably not the right targets for improving the lives of people who are using those services. But we know that what gets measured gets done, and it's just it's easy thing to publish, isn't it? So, I mean, I'm not answering the question, but it feels to me that actually you change the targets so that they are things that co-production and patient engagement can actually lead to. They're outcomes based, aren't they? And they might not be clinical outcomes, they might be life outcomes. And that's where we should be focusing. Getting to that point, I'm not quite sure how to do so. I'm going to hand over to Helen at this point.
Thanks, Anna. I'm nodding in agreement. I think the fundamental problem, Jessica, is I don't think I've met a politician so far that really understands what co-production is. Now, that is a broad sweeping statement. I apologise to any politicians that can do me a whole training session on it. That's great, but that's not my personal experience. And I think targets are really important. You know, again, it's that patriarchal top down, isn't it? We know what's wrong with you, therefore we're going to tell you the solutions to fix it. But actually, that's not what matters to people and communities. And the real shift comes, doesn't it? If we work with people and communities and we put co-production at the heart, the solutions are already there. We know what needs to change where we are. invariably it costs a lot less money, and it will save money because, you know, these big political ideals that will sweeping and change this, that and the other that means nothing to us, you know, that's going to cost you a fortune. Actually, we might have some really simple ideas that can make a huge impact. I also think, and again, this might be contentious, that we don't necessarily sit and wait for our next political leaders, whoever they may be, to think about all of these deep and meaningful questions. If they put them in the manifesto and they say they're going to commit to them, absolutely great. But let's just get on with the doing. Let's work in the way that we know we can. And let's try and cut through some of the next however many months before the next election and the change, or perceived change, I think, according to some of the polling. Because there's work to be done, and I'd much rather ask for forgiveness than ask for permission at this point. And I think there's a real danger that the public are seeing a potential change in government, maybe Labour, as being a bit of a magic wand that they're going to come in and change the world. And I think somehow in all of this, I think all of these organisations like yourselves need to be keeping people real about what the next government will inherit, whether that's Conservative, Labour, or whether we're going to end up with a combined government. You know, there isn't a quick fix, there isn't a super pot of money, and things aren't necessarily going to get better on day 2 after the election.
Thank you. Just to let you know, do you have more time for questions? If anyone in the is listening wants to ask one, do go ahead, because otherwise I will be asking more of my tricky ones. But one of the ones I did want to look at was one that has come in from Joseph Walcott at Prostate Cancer. How do you counter the rebuttal to any of the proposals of how do you pay for it? I'm going to go to Jacob for that. And I think a lot of it lies in the nuance of what we actually want people to do.
Yeah, so I think it's a great question. And we definitely had a bit of pushback on that in relation to the cost of living crisis proposals to kind of the number 2 item, in particular on things like calling for free prescriptions. Because the argument is, well, that's actually a revenue generating stream for the NHS at the moment, and resources are really precious, so we can't possibly give up that source of additional money. But I think the point is trying to highlight actually how it's more damaging for the system to have people not taking up their prescription medication because they're not managing their condition, and then they're using services in a more expensive and sort of demand-driven way that is less good for the NHS overall, is less good for the country as a whole. So actually, it's like pointing to when the question comes up about, well, how are you going to pay for it? It was like, well, actually, you are already all paying for it at the moment. You're paying for it in other areas, though, and they're just not aware of how much it's costing them. So someone being in A&E because they're not managed their long-term condition, because they didn't take their NHS prescription charge, is significantly more expensive to the NHS than just, you know, than that £10, £12, whatever the charge is these days. It shows how often I pay for my prescriptions. So it really does matter that they kind of understand about the cost savings driven by some of these things. I'll also add on the getting the basics right. We talked about having more admin staff or more admin support in structures. We know that you know, the RCGP, the Royal College of GPs, has reported that GPs spend about 30% of their time on admin tasks that could be better done by other professionals. And when I say better done, I don't just mean because you can use the GP's time on clinical care. I also mean, and without any disrespect to our GP colleagues, they're not necessarily the best people at doing admin. So you want kind of, it's a specialist skill, you know, we should be having people support. So we are wasting money at the moment because we're not investing in the right places on getting the basics right. And the public see this, and we see commentary about waste is going up. Actually, more people are seeing the fact that they're getting the letters at the wrong time. Their appointments aren't happening when they're supposed to. Their medication supply is not right. There are all sorts of these the issues that are driven by admin, which are causing waste in the system and are undermining confidence in the system. So addressing them again, Joe, it's a bit saying, oh, well, actually, you are paying for this. You're paying for it elsewhere at the moment. It's how you but in many ways that's similar to the prevention argument, that if we could focus more on prevention, then we wouldn't need so many big acute hospitals doing late intervention care. So it's a difficult sell, but it is saying it is an answer to that question. It's not just about more money. It's about how do you use the money you have got more sensibly. And that speaks to something that Anna said about the public also being recognizing we can't just keep putting more money in. We need to be doing things differently. So yeah, that was just my thoughts. I don't know if Anna and Helen have got any comments on that one.
Yeah, can I just pick up on that? So you're absolutely right. I completely agree with everything you said. And that stat I gave you about 6 in 10 people think we need to do things differently, or the NHS needs to change as well as give it more money. A lot of that is about big change and using different types of services, but a lot of it I think is driven by perceptions of waste and inefficiency, which are directly related to not using clinical staff to do things. You know, the people tell us about, you know, turning up for an appointment and it's been cancelled and the letter hasn't arrived and all of those sorts of things, which is because of not having the right admin support in place. And it's those perceptions of waste and inefficiency that are really, I think you just said this, it's really undermining confidence in the system, because what we are seeing is actually the interaction with the healthcare professional, people are still very, very positive about, but it's all the stuff around the outside and getting there and then, you know, getting the results and the results being in the right place when they go to the next appointment. That's the real experience that they're talking about and that they want to change. And that is about just being cleverer about how resources are used. But it's, as you said, it's the same as that long-term prevention. There's a short-term loss possibly to be able to make these changes. And that's what politicians are going to be scared about, because that might be the, you know, in the immediate future, it feels like you're taking something away to get something in the long run. And that's the difficult bit you've got to get over, I think.
I often think about it in terms of the political slogans. So you don't get anyone saying, what do we want? More administration. When do we want it? In a timely and orderly way, please. But we do need to get them over that hump. Sorry, Helen, I can't ask you there.
No, it's fine. You're just making me chuckle. I couldn't agree more. And I think it's worth remembering, you know, as I said, the NHS at 75 report surprisingly came up with personalised care as a key enabler. And I think we've already got a blueprint for using money differently around personal health budgets. And there was no new money when that came in through the long-term plan. But actually the impact it's made on people's lives is almost unmeasurable. And for me, that's bringing, you know, the quality improvement part of this, that's bringing the patient safety, which are both, for me, they're both dovetailed, aren't they? You know, by using money differently, and I'm going to use my example around personal health budgets from a personal experience. We got a personal health budget for our son. There wasn't a new pot of money. We suddenly got a set of care around him that was far better than what we used to have, and costs on average, you know, £10,000 a year less, because somebody decided that we were a square peg fitting in a round hole and they were going to just ram us until we fitted. But actually, we're doing things differently. So whilst he was having seizures that were uncontrolled and we were really struggling with them, fast forward a period of time once that budget had been in, we used the money to really look in a personalised way. His seizures are now completely controlled. It's anecdotal, but because he's happy, settled, and living a life of his choosing, those incidental bits of money that cost the system, when you look at each contact point, those are gone. But more importantly than anything, he's got a quality of life and he's living a safe life. So all of those, you know, reflections about, you know, we always think about patient safety as the big and the really big instances, don't we? You know, if we think around the Martha's rule things, you know, which are absolutely horrendous. If we personalise care, we also help reduce the health inequalities, which in turn then save the budgets. So let's just use money differently, which is what I think Anna and Jacob have just said. And let's put people at the heart of our health and care system, not, you know, additional extras and inconveniences at times.
Thank you, Helen. It was so good to hear that change is happening for your son. Also, I mean, this is just a personal view, but I do think once we start improving quality of life, that's when you start getting that prevention agenda coming in naturally, because if someone's happier, they're more likely to want to look after their health because they're seeing the value of it. But that's just from a personal point of view. Just before we move on to the final question, I just want to add, because I also helped develop these manifesto answers, Joseph, it's a really interesting question you asked. I think this is why as Jacob started talking, that we have health inequalities embedded throughout, because it's trying to make that argument that, for example, if you improve health inequalities in an area, that would have an impact on A&E attendances. So it might be less important for the public, but in terms of like the policies behind it, you look at the kind of the high users and the people that go to A&E, if you can kind of improve the care for people facing health inequalities, you will start seeing savings in the system directly. And it's also why we asked for that more kind of government-led review of how to reduce the gap in health inequalities, because we do hear some of the more frustrating things around cost of living, for example, is, you know, that benefits issues is a DWP problem. It's not a health problem. And yet quite often we've been trying to make the argument that poor cost of living has a direct impact on DHSC. So a prime example, and I got this one from Jacob, but I love a stat, is there was a 10 percentage point rise in people not fulfilling their asthma inhaler prescriptions in December last year. We would expect to see that have a direct impact on A&E attendances and kind of over winter, but it's trying to make that connection, and that is proving more difficult because you do save money, but you might not save it in the actual department that, you know, that's paying for that thing. So that goes back to that longer term argument of how you make that. We do have one final question. It's a really good one because it really feeds in some of the work that we're doing. So I could have almost had this one planted. But Sadie Asker from NARS, what metrics could be used to show the improvement that is needed? One of the issues mentioned by Anna was around the GP satisfaction rate being low in ability to access, but this is counter to the metric that everyone gets access on the same day. It's almost making the metric making the system work. So I'm going to give this one to Jake, because I know he has lots of thoughts about how to improve metrics, and then maybe Anna, and then maybe Helen.
Thank you. So it's a great question. As Anna was saying earlier, so what we measure in the NHS is what we focus on and what we report on, and then that kind of feeds itself. So you take the GP survey, for example, as a good example. We measure in there things like the satisfaction. We measure in the when people were able to get their last appointment, and we do have performance stats as well that show there are more appointments now than ever before in primary care, and yet satisfaction is as low as it's ever been in primary care. And so this sort of counter idea that we were doing more than ever, and yet people are more annoyed at us than ever. And I would rather actually focus a set of metrics around understanding whether people got what they needed to out of their last interaction with their primary care professional. I would have measures around continuity of care, about did the people who need continuity get the continuity that they needed. So I would be much more focusing my measures if I was to be able to design it from scratch around things that mattered to people, about the quality of the experience. Were they supported to achieve what they wanted to out of the appointment? Those sorts of measures, and I think you could apply those across the board to any service, not just GPs. You could apply it to any service. We have talked internally a bit about wouldn't it be wonderful if you had a set of performance measures for the NHS based around the National Voices I statements, for example, because they've been produced by people that come from users, from communities, and actually they talk about things like, was I listened to? Was I supported? Did I have compassionate care? These things matter to people more than how many appointments were actually delivered. Those sorts of performance measures are less interesting. But I don't draft the questions for the GP patient survey, even though I do sort of sit on an advisory group for it. But I don't know, Helen, Anna, what would you measure if you were going to try and change the conversation?
Thanks, Jacob. I completely agree. And actually, you saved me from having to bring the I statements up. And I think actually some of the qualitative data that is around is really devalued. And I heard somebody recently describe qualitative data and patient stories as data with soul. And I think we should really grab that with two hands. But then the trickiness is about capturing that, and then how do we use that? And the I statements are a great way of doing that. And I think whilst it's really important that we understand what the landscape is, so that we understand where improvements need to be made within our health and care system, I think we genuinely need that shift about what matters to people. What has your experience been? What were the good, what was the bad, and what could be better next time? And I think we need to not necessarily have a culture of blaming and finding somebody responsible for everything. But you know, it's the not our fault culture. And for me, I think there's something about looking at some of those softer datas and bringing those to bear. You know, the patient library with Miles Sibley has got an awful lot of that sort of information in there, and it's a great resource if you've never accessed it before.
Like a good shout out, the Patient Experience Library.
Anna,
Anna?
did you want to come in on that? Because obviously I know that IPSOS does some work on that GP survey. So I'm not sure how much you can say.
Yes, and I'm going to defend it now because it's got those questions in there, Jacob. We've got the how good were they at listening to you and were your needs met. The problem is those aren't the ones that get picked up and get used. And so it's about value. And I always think this. I actually think the NHS in particular is absolutely swimming in like feedback, in whether it's a survey like the GP patient survey or the qualitative work. It's got loads of it. It's just about, does it have the time and the resource and the skills to really do something with it? And that's possibly where we're going wrong. And it's not, possibly it's not valued as much as those really hard performance metrics about how many appointments or, you know, how many beds are there or how many falls, those sorts of things that you hear about a lot. I think actually we should be trying to put patient experience at the same sort of level as some of those operational measures, because I think we've got the data. I think we do measure those things. And just the other point, as I was listening to both of you talk, it struck me, it's particularly around GP practice appointments. One of the things we've heard a lot about over the last couple of years, of course, is that face-to-face versus telephone or digital appointment, and a bit of an obsession about which one's the best and things. And actually, when we've done work on it, preference is getting an appointment quickly, but it's also about choice. And in that moment, sometimes people will want a face-to-face appointment. Sometimes that same person will want a telephone appointment because it's in the middle of the day and actually it's something they can deal with over the telephone. And, you know, this obsession with we've got more face-to-face appointment, that's wrong. Again, it goes back to what you were both saying about that personalized approach to it. So measuring what's important. Did you get what you needed at that moment in time, and did it meet your needs? Not just did you get an appointment on the same day and was it a face-to-face appointment, you know, that sort of thing. So just agreeing with everything I've already heard.
Thank you so much, everyone. We are almost to time. I wanted to thank everyone in the audience for listening, for putting together some really interesting points, and obviously to thank Helen and Anna and Jacob for your time. You can continue to read our manifesto asks. Rosie has put them in the chat and they're on our website. But I think we've heard some really interesting things there, and obviously we will continue to have a busy year. We'll continue to engage with politicians. Still no clear idea of when this election may be, which obviously makes it difficult for the NHS, policymakers, and for the members and the organisations that we support. But I just want to say thank you once again. Any questions, follow up, just drop us a line. If you've got any queries, we will be sharing the slides. And that's it from us. So thank you for taking part, and thanks again to Jacob and Anna and Helen.